All right. Hello, everyone. I'm Youssef. I'm a hospitalist. I've been part with this group for almost a year and a half now. Really excited to give this talk, our first talk as part of the education series for the APP Medical Education Series. And by popular demand, we chose inpatient hypertension. We're open to suggestions. So after this session ends or in the future, if you have any topics in mind that you either want to receive or deliver or something you're just curious about, feel free to shoot us an email, either me or Erica or Claudia, whoever you want, just go for it. So this is the title of the talk. IV Hydra is not evidence-based, but what is? There's a new AHA guideline that came out in 2025 that specifically talks about hypertension. I'm going to cover the outpatient setting very briefly, since we do interact with patients coming from the outpatient setting and we do discharge patients in the outpatient setting, and then the majority of the session will be on the inpatient setting on what to do. And these were our objectives, to just review the most recent guideline and talk about inpatient scenarios. So in general, in the outpatient setting, for you to know, for you to counsel your families, they now even call the range between 120 to 129 and less than 80. They even call that elevated hypertension or elevated blood pressure, imagine. And they call normal blood pressure less than 120 over 80. So basically, everybody has high blood pressure. And that does not necessarily mean that these patients need medications, but the definitions have gone way, way lower. And the way they want us to take these blood pressure medications is basically the patient has to be in the clinic, relaxed, no anxiety, has not walked, has not had a recent cup of coffee, and has been resting. And that's how you check their blood pressure. And in general, they do want us to recommend lifestyle modifications, whether inpatient or outpatient, including weight loss, the DASH diet, which includes fruits, vegetables, salads, non-fat dairy products as well, reducing salt intake, not drinking, and physical activity. And the way that the patients that definitely need medications are patients who have a blood pressure more than 140 over 90 or more than 130 with some cardiovascular risk factors, or more than 130 over 80 with an increased 10-year risk. So now we no longer, they don't want us to use the ASCVD risk score. We've actually transitioned to the PREVENT score, which is more accurate. It's also an MD calc. You should not be doing this on the inpatient setting, but just for your information, that now there's a new score if you want to calculate someone's lifetime risk of MI, cardiovascular disease is a new one. And then the last thing is the new guideline is anybody who has a blood pressure more than 140 over 90 should start with 2 agents. So immediately off the bat, start with 2 agents as opposed to starting with 1 drug, waiting, then adding another. And then the first line agents for blood pressure, you can use the acronym CAT. So it's calcium channel blockers, ACE inhibitors, ARBs, and hydrochlorothiazide or thiazides are the first line. So always remember CAT. If you're going to start any agent, CATs are your go-to agents. Usually you prefer ACEs or ARBs, especially if you have CKD with albuminuria. Heart failure, as you know, or diabetes with proteinuria, that's when you prefer choosing an ACE or an ARB. And like I said before, so if somebody has stage 2 hypertension, which is 140 over 90, they're supposed to start with two drugs off the bat. The reason for that is that, let's say you start one agent like amlodipine, going from, for example, amlodipine 5 to amlodipine 10 has minimal change on the blood pressure. While if you add amlodipine plus valsartan, for example, adding 2 agents works on more than one pathway. So the effect is actually much, much, much stronger. So you don't want to just uptitrate 1 agent, you want to do 2 agents. Claudia.
Hey, yeah, I had a question about the ACE and the ARBs with CKD. So I know a lot of times on the inpatient side, like when someone has an AKI, we'll hold an ACE or an ARB. Obviously, an AKI is acute, whereas CKD is chronic. But I don't quite understand how ACEs and ARBs can be hard on the kidneys or cause injury to the kidneys, and yet also good for CKD.
Yeah, there is a paradox there. So how do ACEs and ARBs work in relationship to the kidney? So they vasoconstrict the blood vessel that is efferent to the kidney, so after the kidney, and it dilates the vessel before the kidney. So if somebody has an AKI, they're at risk for more AKI if they get a ACE or an ARB. So that's only in the setting of AKI. However, in patients who have chronic kidney disease, or if you stretch the timeline to the long term, studies show that use of ACEs or ARBs increases the creatinine just slightly in the beginning, but then long term it plateaus. It's very, very, very flat, and is actually protective against CKD. So short answer is, in the acute setting, in a setting of AKI, you want to hold it only because it can have deleterious effects only acutely. While on the chronic setting, if you start an ACE and ARB, it actually protects from progression of kidney disease. Really good question.
Thank you.
Yeah. And anybody who has any question, actually feel free to just raise your hand, jump in, unmute. This is actually hoping to make this as interactive as possible and get to whatever information you want to get to. So secondary causes of hypertension is they just want us to think about these things in general. Anybody who has stage 2 hypertension, so very elevated blood pressure, sudden onset, if they're younger, or if they have diastolic high blood pressure in older patients. And then anybody who has end organ damage. Then this study came out a few years ago, New England Journal of Medicine in China. There's our new salt substitutes that actually have potassium in them. So if a patient does not necessarily have CKD or does not have issues with hyperkalemia, this substitute is KCl. It tastes exactly like salt. I use it at home all the time. It has a cardiovascular and a mortality benefit, to be honest. It's really, really good. It tastes a little bit metallic. Out of personal experience, I don't use it in food, but I use it as on top of food instead of salt, and I replaced it at home. It's potassium chloride, tastes like the same, and has a mortality benefit, if you can imagine. Very few things in medicine have a mortality benefit, and this is one of them. Yeah, it's kind of expensive. Depending on where you work. So grade, I don't think a lot of people can afford it. It's maybe $10 for a couple of these bottles, but still it can be prohibitive. But if you want to counsel them and they're motivated, interested, or really like salt, I've definitely used this with my patients. I tell them, hey, there is a salt substitute as long as you're not having potassium issues. So just to recap, in the outpatient setting, lifestyle. Start with CAT, which is calcium channel blockers, ACE and ARBs, and then thiazides. And now we're going to go to the inpatient cases. You don't have to scan this, but this is only for if somebody's watching the recording. You can get the cases here. I'm going to give you the cases now, and I'm hoping you could solve through them, and then we can discuss it after. So I'm going to do a minute for each slide, and then we'll discuss them together. And I'm going to stop the recording now, and then we'll come back and go through these cases. So this is the first slide, and then I'll go to the next one. Cases together. So first of all, inpatient hypertension is very, very, very common. So 80% of patients have at least an elevated blood pressure reading, and you all see that every day. About 10% of those patients even develop severe hypertension, which is more than 180 over 110. And 1 in 10 of these patients are discharged on new blood pressure medications. So the message I'm hoping to share today is that treating inpatient hypertension is potentially harmful. So there are a plethora of studies that have come out in the last couple of years showing that intensive blood pressure treatment inpatient causes harm. So this includes AKI, myocardial injury, ICU transfers, strokes. This is treating that blood pressure causes strokes, longer hospital stay, falls, and no improvement in long-term cardiovascular outcomes or survival. So if I'm saying okay, treating inpatient hypertension is bad, so what should we do instead? So usually you want to see is the blood pressure causing the symptoms, or is the patient having symptoms causing them to have high blood pressure? Let's say things like nausea, pain, anxiety, withdrawal, urinary retention, or constipation causing them to have high blood pressure. And in the past, we used to call it hypertensive urgency. But now the clinicians notice that, okay, like there's nothing urgent about it because we don't have to treat it. So we no longer use the term hypertensive urgency. This was like canceled officially. And we now say the term severe hypertension, just referring to higher blood pressures. And let's go through the cases to see that sometimes there is end organ damage and whether we should treat or not. So this is the first case. Anybody want to volunteer and take it?
I'll take this one.
What's your vote, Erica?
So I would not start an IV hypertension medication on this person, even though they have a headache. The blood pressure is high. First thing I want to know is if, like, let's say it's an ED setting, does the patient take medicines? Are they compliant? And if they are not, I would resume their home meds first.
Yeah, I love it. I love it. So I think a few things you did there right is that one, like the headache is, even though it is a symptom, it's hard to say if it's related to the blood pressure. Maybe they just have a headache, maybe they just have a migraine, and maybe that's causing their blood pressure to be high, right? And then, like you said, like, could there be a trigger? And then are they on home meds that you can resume? So I agree, it's not an emergency and no IV antihypertensives. We can go to the next one. So this patient presented with tearing chest pain fading to the back with diminished pulses on the left side compared to the right. Any votes on this one?
I could take this one. I mean, this seems, it sounds very much like a dissection. So I would not want to lower the blood pressure with IV medications. I would be calling CT surgery right away, I guess.
Yeah. So 100%. So this is a dissection. You're right. You want to call CT surgery stat. You want to get a CT dissection stat, and sometimes you do treat with IV antihypertensives because it's a dissection. So they do prefer like beta blockers, IV beta blockers, to be started, like esmolol, short acting, to prevent. So in this case, it can be considered an emergency just because of the dissection. But you're 100% right that this is an emergency, and you sometimes do start for this scenario. This patient is probably having an MI, so ST elevation is 2 or 3 AVF. Any votes? And you can put it in the chat as well.
I vote yes for IV.
Okay, I agree. So like maybe objective signs of end organ damage. So probably, yeah, you want to treat like an emergency, probably do start like IV antihypertensives. Let's see. Next one. So shortness of breath for 5 hours with tachypnea and a chest x-ray that shows pulmonary edema. Any votes? Karen wants to diurese. I love it.
I agree as well.
Awesome. And I'm going to get to this case shortly after, soon. And let me skip to this slide. So according to the guideline, So we throw this word around like liberally. We just say any target end organ damage you want to treat. In reality, there's only a few things that we consider to be target end organ damage. So this is according to the guideline. These are the things that objectively are target end organ damage. And I highlighted here in red the objective syndrome. So PRESS is a syndrome where a patient gets confused and then you get an MRI and you see MRI changes on their MRI. Like, okay, this is objective. Same for like retinal hemorrhage, papilledema, an intracranial hemorrhage, a stroke, ACS, like acute coronary syndrome. You're gonna know they have ACS. It's very objective. Acute aortic syndrome, so dissections, penetrating ulcers. These are all very, very objective. But if you notice, the rest are kind of subjective: acute heart failure, pulmonary edema, AKI, and we'll get to these shortly. So a lot of times we treat these like hypertensive emergency, but the paradigm and the question is, does high blood pressure cause an ICH, a stroke, or intracerebral hemorrhage? Or in the setting of intracerebral hemorrhage, is high blood pressure bad? So that's the really tricky part. So those were the studies. So they were like, oh, does acute high blood pressure cause a bleed? Or does chronic high blood pressure cause a bleed? And the study showed it's actually chronic high blood pressure that causes bleeds and strokes. So the reason why, for example, if somebody has an intracerebral hemorrhage, we treat their blood pressure is not because the blood pressure is causing them to bleed. It's because if you have a bleed, then not treating the blood pressure will cause it to be worse. So it's not necessarily a very proximal cause, but if it occurred, then you need to treat the blood pressure. What about stroke? So this one is like, I thought groundbreaking even for me too, because we learn in medical school, in PA school, and training and everywhere that, okay, if we don't treat the high blood pressure right now, the patient is gonna develop a stroke. Well, guess what? They studied this, like, how does high blood pressure cause stroke acutely, like now, or does chronic high blood pressure cause stroke? And you may have guessed it already, it's actually the chronic arm that does. So elevated blood pressure over weeks to months causes arteriolosclerosis, so changes in the blood vessels over time, and then that puts them at risk for stroke. So even if you have a patient with a stroke, you page neurology and they tell you, oh, let's do permissive hypertension. So this is also like, consider your paradigm, because if you consider that high blood pressure causes stroke, then why is neurology telling us not to treat it in this patient who just had a stroke? So it's a paradox, right? So in patients who have, if hypertension causes strokes, why do we do permissive hypertension in exactly those patients? Well, the reason is that if you do have a stroke, your brain auto-regulates and secretes hormones for the blood pressure to be high. And turns out that if you have a stroke, high blood pressure is actually good for cerebral perfusion. And it's part of your body's defense mechanism to cause perfusion of the brain, believe it or not. And if you notice in patients with stroke, somebody has a stroke, you do permissive hypertension for 48 hours, and then you start treating the blood pressure. And the reason you treat the blood pressure is to prevent the chronic damage. And here we're separating between acute blood pressure versus chronic blood pressure. So stroke is not necessarily the cause of, high blood pressure is not necessarily the cause of end organ damage, but sometimes it can prevent complications. For example, in PRESS or hypertensive encephalopathy or intracerebral hemorrhage or stroke, in the acute setting, you're not treating the high blood pressure to prevent this from happening. if this happens, you treat blood pressure to prevent further complications. It's the same for dissection. Usually the cause is not the acute high blood pressure causing the dissection. It's actually they have a dissection, and if the blood pressure is high, it will worsen the situation. And that's the same for MI, because we all know that MIs are caused by plaque rupture, right? So why do we say we have to treat the blood pressure? Because we don't want to make it worse, and we don't want to put extra stress on the heart if they're having an ACS. Before I go to the next slide, anybody have any questions about this portion? All right. So we can go on to the non-objective one. So we said that okay, stroke is objective, but heart failure, pulmonary edema, AKI, like how do we decide if we want an IV drip versus just diuretics, like y'all are suggesting? So what is the time limit that's like, okay, this is a good time limit? Like, is 5 hours of pulmonary edema like an emergency, while 2 days is not? So what is our cutoff? So for example, in this case where just going through the answers quickly that we talked about before, this patient had the one that Erica said, we're probably not going to treat like an emergency, no IV antihypertensives. Second one, this is an interesting one. So a patient came in with chest discomfort for 2 hours. EKG is normal, and the trope goes from 30 to 35, and the blood pressure is high. Is this an emergency, and do we treat it with IV antihypertensives? Any votes?
I would not consider this an emergency and would not treat it with IV.
Okay, I love it. I agree, but why not?
Because has no the EKG has no STT changes, and that troponin is a very, very minimal rise, and overall 35 is not really that high.
Yeah, exactly. And what Claudia is saying, like, this is not ACS. We have cardiac injury. So notice that we have end organ damage, but we don't know if it's related to the blood pressure, right? It's not ACS. So I agree. So no need to treat like an emergency, but this is a hard scenario, right? So usually if there's no anti-ACS, you're not going to do an IV antihypertensive. You just treat the trigger. Like you might do a stress test, you might work them up, but you won't necessarily treat it like an emergency. So yeah, I agree. No and no. This is similar to the case we had before, but it's 4 days with a low EF. So a patient came in with dyspnea or orthopnea for 4 days, blood pressure is high, and they have a low EF. Is this an emergency or not?
I wouldn't treat this. This is not a hypertensive emergency. But you would treat with diuretics because that's gonna help with the blood pressure once you remove some of the volume.
Yeah. So it's not an emergency. It seems like CHF. So you want to diurese. You can consider treating with oral meds, right? You can do GDMT, as you know, but you don't do like IV antihypertensives. So in this one, we were comparing between the same case, is this an emergency or is this heart failure? So we called it heart failure in this case. But now I want to go back slightly to this slide. So this slide. So a patient has shortness of breath for 5 hours and is currently in respiratory distress with tachypnea, and a chest X-ray shows pulmonary edema and his blood pressure is very high. Is this an emergency and do you give IV antihypertensive? So it's very similar to the scenario before, but now it's 5 hours as opposed to 4 days. Yeah, so we have some votes for yes. Yes, it is an emergency. So anybody can name the syndrome or have a name for what's going on?
Is this flash pulmonary edema?
Yeah, exactly. This is flash pulmonary edema. The new name for it, or a similar name for it, is SCAPE. It's called sympathetic crashing acute pulmonary edema. So in these patients, it's very hyperacute. So it's over hours. Like somebody is fine, and then suddenly they're very hyperacute. They have very high blood pressure, and in this case, the treatment is very acute. So you quickly want to start a nitro drip. You want to put them on BPAP. You want to put them on high dose diuretics, and these patients typically get better within hours. Like if you've seen this before, it's incredible. Like they come in very, very sick, and then within 5 hours they're fine on room air, and it's very like treatable. So in this case, notice like 5 hours. We said, okay, yeah, obviously, let's do it. But if it's like a few days, then it's more likely to be CHF. Okay, this was the cool one too. We have a high blood pressure and an AKI. So creatinine went from 1.5 to 2. Charisse votes no.
I say no as well. I mean, it's just a slight bump. It's a bump. That's it.
Yeah, I agree. So the guideline says puts AKI there on as target end organ damage. But again, like you all are alluding to, not everything on there, just because it's on there doesn't mean that you necessarily have to treat like an emergency. So the question is the hypertension causing the AKI, or is the AKI causing the hypertension, or is like something else going on that's causing like both high blood pressure and AKI? So yeah, if it's like a small bump, I wouldn't treat like an emergency. Let's say the creatinine went from 1 to like 10. I think it's you could potentially treat like an emergency, but you just have to remember to rule out like other etiologies, like you rule out obstruction, rule out glomerulonephritis, think about stuff, but you can't treat it like an emergency if it's like a massive bump. But you just have to be careful to keep thinking about other things and not anchor to the blood pressure being the cause of the AKI. So in terms of if it is an actual emergency, the agents you can choose per the guideline are like nicardipine, nitroglycerin, labetalol. They do recommend IV hydral. I recommend you never use IV hydral. It's very, very erratic and unpredictable. So the same dose can cause massive changes in blood pressure differently in different people. So I've never ordered it in my life, to be honest, for that reason. And there's like a full phenomena on the internet of hate on IV hydral, of like clinicians from all over the US who are anti-IV hydral for that reason. So I recommend you do the same as well. So to recap, don't treat hypertension in patients unless they have target end organ damage. Treating the hypertension actually causes harm. So we have a higher threshold to treat, and try to remember the thresholds to that cause you to have like a hypertensive emergency. So things like stroke, ACS. But if somebody's been going on slow, going on for days, it's usually not a hypertensive emergency. So this is the algorithm. So in inpatient hypertension, first question, is it an emergency? If yes, you do IV antihypertensives and you'll have the criteria. If no, go see the patient and ask them about triggers and time. So ask, are they anxious? Are they nauseous? Are they vomiting? Are they constipated? Do they have retention? Do they have withdrawal? Treat the trigger and give it some time. Like I'm empowering you that none of the complications of hypertension, other than flash pulmonary edema, are very hyperacute. Most of them are chronic. So it's okay to wait and just give it time. Let's say the blood pressure is still very high. So the question is, do they have, you can consider if they have heart failure. If they do have heart failure, this is one of the few scenarios where I might give oral PO hydral. Like let's say that someone is already on GDMT, then and their blood pressure is still very high, then I do oral hydral PO. Or let's say their GFR is 10 and they can't take ARBs, can't take SGLT2s, then I might do PO hydral for CHF. Otherwise, just do outpatient follow-up, start their oral home meds, or if you want to start an oral agent, you can. The only thing is you don't want to target a number. So you can start one agent if you want, but I usually hold off targeting a number because it causes harm. I'm going to pause there for questions, and then I have a few more slides left to go through, but pausing for questions, any like scenarios you've been in that were tough or reflections?
I have a question about like how much time do you give it before you start kind of thinking about taking more steps?
I think the answer is, do we have a trigger or not? So let's say somebody is like nauseous and vomiting and they're retching every day for 5 days. I honestly will not treat their blood pressure because I have a trigger and I haven't treated the trigger, right? So I do very aggressive treatment of the trigger. Let's say somebody does not have a trigger. I think the time is like, I would say over days. And then after a few days, I would start just one agent, oral agent. Just don't target a number. Don't be like, I want to make your blood pressure normal. Because if you make it normal, they leave the hospital, they get comfortable, and then their blood pressure drops, and they get falls and AKI and come back to the hospital.
Thank you.
Yay, Karen had a question
Okay.
about how do I deal with the paging. I'm going to get to that in this next slide.
Okay, I have a question. For someone, for example, that came to the hospital, I mean, his blood pressure has been normal the whole time, and overnight, all of a sudden, is in a 110, 120, and without any symptoms. I'll give him some times. It doesn't have no trigger, anything. So for how long we have to observe this kind of patients, given that, like, the rise in the blood pressure is so acute, and then without any trigger?
To be honest with you, like, you don't have to. There's no hard indication for you to treat. So the answer is, do you have to treat it overnight? The answer is no. Can you start like one oral agent? You can. So the answer is, you don't have to. Nothing will happen if you don't do anything, if you just let it be. If you feel like starting something, I would do like max one agent oral, like PO hydral, for example, or another oral agent. But just remember that this is causing harm. So you don't want to just treat a number. The best case scenario is you just let the day team deal with it, to be honest, and let's like have them follow it over days. Like, there's no reason unless you find like any signs of end organ damage or an obvious trigger.
Okay, and the other question will be like in the first scenario, let's say that this is a patient that's basically never been diagnosed with hypertension, and coming to the hospital, and he has, like, we find that he has a systolic of 210 or 220, without any end organ damage also. How, like, what should be the target before we discharge such a patient from the hospital?
Yeah, really, really good question. I think we work in hospitals where like our patients don't have access to primary care, which makes it even harder because like, oh, like if you don't treat this, nobody's gonna do it. The answer is, do not target a number. So you should not say like, oh, I have a number in mind and I want to get them to that. The answer is, give it a few days. If it's still high, then the day team should add 1 to 2 oral agents max, like either a calcium channel blocker, an ACE or an ARB, or a thiazide, and let them follow up outpatients. You should not be like, oh, I want to normalize their blood pressure, because that causes harm.
And my last question will be like, sometimes we receive some patient with like, on drip from ECC. It's not something that we necessarily have to deal with overnight, but for how long a patient should be on a drip? Because I've seen some patient on a drip for about like more than 24 hours, and without any improvement in their blood pressure. So for how long the patient, like, should be on a drip, like, although there's no improvement that we're seeing?
Yeah, yeah. Usually, if it is an actual hypertensive emergency, most of these conditions will improve within a day. Like the condition that's causing it to be an emergency. You know what I mean?
Yeah. Okay, because sometimes I had a feeling that a patient develop is kind of resistant to the drip, but still on it. I don't know if it's the provider means to stop it or change, but the patient remains on the same drip, although that is not working.
Yeah, yeah. I see what you mean. A lot of times, these scenarios happen in patients with end-stage renal disease. So for example, you might have like a volume issue and not a blood pressure issue, where these patients will miss dialysis and they come and they get a drip, and then there's no way you're gonna drop it until you do dialysis, for example. So you might want to consider, is there like another mechanism? Like, are they volume overloaded, for example?
Okay. Thank you.
Yeah.
I have a question.
Yeah.
What is the best way to transition a patient off of a drip? Because usually, like say sometimes we'll have patients on a drip and their blood pressure starts to come down to normal, and you start them on PO and kind of leave them on the drip for about I've left them on the drip for about an hour, but then there are times where I may this is at the end of my shift. I might come back and then I see that the patient's blood pressure has maybe rebounded. And in that instance too, my second part of the question would be, would you resume the drip, or would you kind of just either add an additional PO agent or up titrate their agents and see how that works before you would add the drip back on?
Yeah, yeah, that's a really good question. Uh, I think it all depends on what is the end organ damage that I'm treating. So, like there needs to be a reason why I'm putting this patient on a drip, and what is the reason why I'm putting them on a drip? Like, is this press, for example? Then I would want to keep them on the drip longer until I would not target a number. I would target their number and their improvement in their encephalopathy, for example. Is this like an intracerebral hemorrhage? Then you want to target like very low numbers. Let's say something like a little bit iffy, like AKI or heart failure. Then you're generally it's okay to turn. You don't want to target a number. You don't want to say, oh, I want to target this specific number, and then if I stop it, they're gonna go back up. I'm not chasing. I'm not gonna be chasing a specific number to treat. Because otherwise they should not be in drip, right? If it's none of these etiologies, and if it's none of these etiologies, and the person during the day is treating something, and you're trying to transition them off, I wouldn't stress too much about it, because it's like this is not evidence based actually. Like you should, so don't worry about like their blood pressure going back up.
Thank you.
Yeah, yeah. Any other questions, reflections? I'm gonna talk about the nursing or how to approach nursing. Yeah, and this was Sidibe's question as well. Like, what if their blood pressure is really high? Same thing, just assess for end organ damage, and then think of triggers. If you don't find any, you can consider an oral agent. You don't have to do it overnight, to be honest. You can if you want to. This is only for like anxiety, for the nurse's anxiety, to be honest. No, I've never seen a blood pressure this high, but I'm exaggerating for effect. But you can't do an oral agent, for example. So you're doing this and everybody is like really angry at you. The nurses are hammer paging you 10 times a day. Other members of like maybe other teams are like, oh, okay, like what's going on? So what are they thinking, or why are they so mad at you? Well, they're perceiving harm. So in their mind, we've taught nurses, we've taught our patients, we've taught our loved ones that, hey, blood pressure is bad, therefore high number equals bad, low number equals good. And to the nurses, they're like, oh, why is this provider not treating my patient? Like, are they careless? Do they not care? And so their perception is like, oh, you're not caring for this patient when your goal is to actually prevent harm. On the other hand, like other providers treat it. Like imagine if the nurses call the surgery team is gonna do IV labetalol for anything. Or if they call like any other like residents, imagine they deal with so many like teams that the other teams treat it and you tell them like, hey, I'm not gonna treat it. They're gonna be so confused. So this is a hill that I am willing to die on. I will not like start antihypertensive inpatient unless I really have to. So what I try to do now is try to use it as like a teaching opportunity. A lot of times the nurses perceive that this is causing harm. So a lot of times I have to assess this patient in person and see the patient to affirm the nurse that, hey, not only am I just saying this over the phone, over the chart, like I saw this patient and I don't think this is an emergency, even though they just have a headache, but let's say, but no stroke. I'm just gonna call this inpatient hypertension without end organ damage. So I communicate that with the nurse. They say, hey, I evaluated them. I don't think this is an emergency. And then I try to make it come out of place of curiosity. So I say like, hey, did you know that there's a new guideline that just came out that says that inpatient hypertension causes harm? And like, oh, wow, is that true? Even though we've known this for like years, but I try to make it sound like this whole new thing. And the guideline did come out this year. So I say, yeah, like this new guideline came out and even some cardiologists are part of this guideline. And they're like, oh, wow, that's exciting. So I end up like sending them the guideline and they actually do enjoy it. I did create an inpatient hypertension dot phrase, which is this one. Feel free to copy it. But it basically says that unless they have like hypertensive encephalopathy, intracranial hemorrhage, stroke, flash pulmonary edema, otherwise it's not an emergency. And treating it, not only is it not beneficial, but also causes harm. So you don't want to cause your patients harm. There are plenty of resources on this. There's a Things We Do for No Reason paper on it. There's a Curbsiders podcast episode on this. Dr. Noble Malik works at Midtown. He's the speaker on this podcast episode. So any thoughts, reflections about this? Yeah, Kenrick.
Hi, everyone. So I just have one example, and you may have covered this, but I just wanted a little bit more clarification. So I'm not sure how old the young lady was, but I believe she was probably in her 60s, came in, ended up having a stroke. I'm not sure whether it's embolic or ischemic. Either way, she was having I think I had seen her maybe 3 or 4 days after her stroke. And at that time, they were still allowing permissive hypertension, which was odd to me. Came back the following day. I think antihypertensives had started to be added on. She had chronic hypertension. So a day team was addressing that. She was pretty resistant with her hypertensive medications, even being added on. I think initially she was a little delirious, so they think that was contributing to it, added Zyprexa on. And so I had seen her subsequent days, like 2 and 3 days back to back, right? And so I was called, blood pressure still 170s to 190s, systolic, diastolic, 90s to 110s. Nursing kept calling, hey, if there's anything that we could do to get her down, right? And so I assessed her at the bedside, and encephalopathy came to question because how can we assess that, right? If a person is agitated, delirious, she still had a mild AKI. I didn't know if that was contributed to some of the things that she had been on during the hospital stay. She started to have epistaxis. So a lot of things all considered, I didn't give her anything in that time. I was just treating her symptoms, right? However, day team was just pretty much still coming up against roadblocks as whether, up titrating her medications because she was very resistant. So what do we do in that case, or what should I have done in that case?
Yeah, so to recap, patient already had a stroke and day team said to do permissive hypertension and you're evaluating them overnight and they still were hypertensive. Is that right?
Correct. I mean, I think permissive hypertension was for only a couple of days. However,
Okay.
they started to add on antihypertensive medications to try to get her blood pressures, down.
Yeah, like I think similar to the principles before, like, is this an emergency? You already know there is a stroke. You're not worried about a new stroke. It's more like they're just encephalopathic. Since there is no objective target and organ damage, I would just let it be. Like, it's not beneficial to like target a number.
Mhm. Okay.
Like, you want to give time for the oral medications to kick in.
Okay. Okay. Thank you.
But the nurses will freak out. That's the thing.
Yes, they
Which
do.
is okay. Which is okay. Like, you know what I mean? Like, they're perceiving harm. They're not saying this out of like, you know what I mean? Like, in their mind, they're like, why
Sure.
is this provider like ignoring my, you know what I mean? They are like, they believe that you're causing harm to the patient. In reality, the data has changed.
Thank you so much.
Yeah. Any other thoughts, reflections?
Well, I don't know about for everyone else, but this has been super helpful for me. I think a big part of this will be kind of that education for nurses, because we all know and get those pages from them all the time. But I think like kind of getting the confirmation that we don't need to be chasing all these things is very helpful. And like going through kind of the specific cases for me, it was super helpful. So I'm very grateful.
Awesome. Well, I'm glad. Yeah,
Thank you so much.
it's liberating.
I just have one question, because I feel like a lot of this has to do with the nurses perceiving that we are doing harm. And I'm just wondering if there's any way that we can maybe speak with the nursing director, because a lot of the stress, even when it comes when we're admitting patients, transitioning from the ED to the floor, there's a lot of pressure where they won't even accept the patient to the floor if their blood pressure is within a certain range. And obviously, we don't really want to be treating these blood pressures in the event that the patient is asymptomatic. In most cases, they are asymptomatic. I wonder if there's an extra step that we could do there to maybe get them better informed, so that way we can decrease the frequency of calls that we're receiving to treat this blood pressure, and also to give the nurses some feedback that we don't have to have these perfect numbers for a patient to make it to the med surg floor.
Yeah, I 100% agree. I think it's just like an uphill battle. It's just like there's education for providers, because the ED providers will treat. So it's like, even like, imagine that you're a nurse and you're like, I called the ED provider and they treat, and I called the inpatient provider and they said no. So it's just like it's something we have to keep going, keep educating. I've spoken to like the unit directors who keep talking to nurses on their floor on their unit about these issues. But I think there's like so many teams. I think we should just keep doing it. I agree, Karen. There is room to talk to like nursing team, nursing educators for this specific goal. I don't know who specifically we would talk to, but there's definitely room for improvement.
Yeah, that's true. Because at this point, I don't know anymore. Because, like Erica said, sometimes we have this patient coming to the med surg floor, and they will not take the patient from the nursing ED. So, given that the patient is asymptomatic and then they don't want to take a patient with blood pressure of 200, okay, what can I do in this case? Because I don't want to treat the patient either.
I think one thing which is like hard to say, but like you can just ask them like, hey, show me your floor policy. Like this happens a lot of times where they tell us like, hey, we can't take this patient on the floor. Like, oh, okay, show me the policy, and then it's not on the policy. It's just hard to deal with because sometimes they don't feel comfortable with it. So I try to like fight the good fight. Sometimes if you really have to, like you can do like oral hydral once, but I try not to do it personally and try to like fight the good fight. I know sometimes it's like hard and it can take time and effort. Or their home meds, for example, but let's say they have withdrawal, like they're okay with it. And usually I just try to communicate, educate, talk about the guidelines, etc. But I don't have like a quick fix.
Yeah, it depends on the flow because
Exactly.
some of the message flow. I mean, it's like some flows are okay, but some others are very categorical when it comes to taking those patients. And
Exactly. Yeah.
and then sometimes it feels like we don't have that much in our power to fight them.
I think deferring to policy is a good one.
Okay, we'll try that.
Yeah, I wanted to support my yeah, for night shift, for us at nights, yeah, the really hard part is one of that, the pushback from nursing and the frequent calls, and then the escalation sometimes to the supervisor that we're not treating the patient. And the the aggressive nursing notes about all that, like, doing this. But one thing that I always do too sometimes is I might give hydral oral just to placate, but also tell them, we treat the patient and not the numbers, right? Like just focus on the patient. If the patient is symptomatic, we just continue to observe. But on the other hand, the dilemma that I often have too is I know now we're supposed to wait, make sure there's no organ damage and all this stuff. But what about cases where at that moment or in that period of time where the patient's blood pressure is really high, they're not showing any triggers, no evidence of end organ damage, all of this stuff? We don't treat. Then a day or two later, they have a severe, like they go from 0.5, 0.6 creatinine, go up to like 3, or all of a sudden they develop like a brain bleed, from chronic hypertension. Could maybe if we had treated the patient in the time that we're waiting, they weren't showing any evidence, could that have prevented any of that sequelae from not treating their blood pressure? Like that's a dilemma I have too sometimes. Like how long should we actually really wait?
Yeah, so they did a study where they compared patients with intracerebral hemorrhage, and they compared the patients who had higher blood pressure before and patients who had normal blood pressure before, and they had equal rates of bleeding. So even though we're like we were taught forever that hypertension causes all these things, it's not necessarily true. It causes like small vessel disease, but if they bleed, it causes it to be worse. Yeah. And now we have like data that treating it causes harm instead of benefit. So you already know that it can cause harm. You know what I mean?
All right.
Awesome. Well, thank you all for joining. Hope you all have a great night.
Thank you so much.
Thank you,
Yusuf.
Yusuf.
We
So,
really appreciate
Thank you,
it.
Yusuf.
Thank
Thank
you.
you.
Thank you.
Very beneficial. Bye-bye.
Yes, it was. Bye.
Thanks. Bye.
Thank you. Bye-bye.